Afternoon, everybody. Welcome to our webinar on Proposition 1 and how it may affect mental health services in our county. I am Leslie Brown. I'm chair of the Government Policy Committee for the League, and I'm also a member of the county's Board of Behavioral Health Board. Our Government Policy and Social Policy Committees thought it would be of value to host webinars on propositions voters have approved and how these initiatives have impacted services in our county. And we chose Prop 1 due to the clear implications that this new approach to mental health services would have on the services that are currently being delivered in the county. Before we get started, there are a few housekeeping items that you should know about. We're scheduled for an hour and we're going to need to stick to that. We will take questions through the Q&A function. The chat is not functioning. You can submit questions at any time and we'll answer the questions during the Q&A session following the 3 presentations. We'll get to as many of those questions as we can, time permitting, and I apologize in advance if we can't get to the one that you've asked. We will be recording the webinar and you'll be able to access it online on our website or on our YouTube channel in a couple of days. And also, the League's website and contact information, as well as the panelists' contact information, will be on a final slide that we'll put up at the end of the webinar. I'm going to turn this over now to Glenn Silloway, who is the Social Policy Committee Director for the League, and will be the moderator for this webinar. Glenn?
Good morning, everybody. Thanks, Leslie. I would like to put some context on this before we get started. It's a big issue, and it's been burning for some time. Proposition 1 is changing a lot. As most of you know, I think everybody here is, most of you are in the choir. Some of you may need some context, so here it goes. Prop 1 was on the ballot in March 2024 and proposed huge change in how we deliver mental health services. It was fairly controversial. In voting, the proposition passed with just 50.2% of the vote, a majority of just over 25,000 votes out of 7.2 million cast. It did 2 big things. It changed the Mental Health Services Act that was passed as a ballot measure in 2004 to become the Behavioral Health Services Act. It expanded the service spectrum to include substance use disorders and explicitly identified a service population that included persons with substance use disorders who were at risk of or experiencing homelessness. The proposition did not change the 2004 MHSA funding mechanism. That's the one that levied the 1% annual tax on incomes over $1 million. The measure did also include a $6.4 billion general obligation bond, funding for supportive housing, residential treatment centers, and added slots in treatment programs. Some of this funding was earmarked for veterans. In the run-up to March 2024, organizations and interest groups lined up for and against the proposition. Supporters included Governor Newsom, big city mayors, perhaps you, perhaps not you. The prominent supporter included the NAMI, California, and they supported the measure for a number of reasons. They mentioned that it would increase state oversight, and they supported the broader spectrum of services to help more individuals and families, with the bond-funded supporting actions to improve the housing and homelessness crisis in the state. Opponents included disability and civil rights advocates who objected to a late amendment on the measure that would allow it to be used for involuntary treatment. The League of Women Voters California urged a no vote on the measure, together with the Howard Jarvis Taxpayer Foundation. It's a very unlikely pair. The League's reasons included they opposed the idea of the inclusion of involuntary treatment. They believed that the community care emphasis in MHSA was more effective than a more institutional treatment. There's an assumption there. The proposition would reduce county flexibility and scramble current programming. And finally, that the changes of the size of Prop 1, which was a big change, should be passed by legislation and not by a ballot measure. So with all of this in mind, let me turn to our expert panel. Thank you for putting that together, Leslie. And we want to learn more about how the early stages of Prop 1 implementation in our county are working. Our first panelist today is Christina Rajlal. Christina is the Division Manager for Prevention and Outreach Services for the San Luis Obispo County Behavioral Health Department. She is the county's Mental Health Services Act coordinator at the state level, managing and representing all county MHSA programming for behavioral health and substance use care. She is also a professor of industrial and organizational psychology at Bakersfield College. Christina has worked in these fields for 25 years. So Christina, take it over.
Thank you, and good afternoon. Let me get my presentation up here. All right, you should be able to see that. I'm going to pop the chat up just in case there's some questions that might come in. So again, I'm Dr. Christina Rajlal. I am the Mental Health Services Act coordinator for San Luis Obispo County. I want to share with you a little bit of the foundation of what the Mental Health Services Act is. So as Glenn mentioned, the Mental Health Services Act came to voters in the state of California as Proposition 63 back in 2004. It was passed and enacted in 2005. It created a 1% tax on the millionaires in the state of California. That money, that taxable income goes up to the state. It gets divvied down. There's some that is taken off the top and then it gets divvied down to each county depending on a couple different factors, including population size. And then the county receives allocation based off of that certain formula at the state. Those get paid 2 years in arrears for the Mental Health Services Act coming to the county to be able to implement. The dollars, when they flow to the county, get distributed by component funding. There are 5 current components under the Mental Health Services Act, which is inclusive of community services and supports. We call that CSS. PEI, which is prevention and early intervention. Innovation, which the acronym for that is INN. Workforce education and training, also called WET. And capital facilities and technological needs, also called CFTN. So each of the programmatic decisions that are made on behalf of the county of what we use those funds on are organized in those 5 funding buckets. All of the dollars spent through the Mental Health Services Act must be done with community planning, meaning the community has a voice through the stakeholder process or the community advisor process. And all dollars must be spent within 3 years. And then the county also keeps what I call like a rainy day fund, and that is called the Prudent Reserve. And so that is how the current Mental Health Services Act dollars operate. Now, we are definitely moving towards a change. We are now in May, and so we're about 14 months out for this flipping of the switch to MHSA transferring over to the BHSA. In this slide, you can see that when the governor kind of devised the plan for Proposition 1, it was inclusive of a larger vision, which we call the BHT. That's a behavioral health transformation. There are 12 moving components. Well, all these components listed here on this slide are components of the larger vision of the behavioral health transformation. BHSA, or the Behavioral Health Services Act, part of Proposition 1, is just one of these many components. Along with that is CalAIM, that's already moved forward a couple years ago. Something that's come online this year called BH Connect, and we'll be walking through BH Connect in the next couple years as it goes into full implementation. There's something called CYBHI, that's the Children Youth Behavioral Health Initiative. That moves a lot of funding into the school-based platform where services can be rendered in the school-based setting of our elementary, middle, and high schools. Then there's the Medi-Cal Mobile Crisis, the Behavioral Health Bridge Housing, CARE, SB 43 LPS, 988 expansion, and the Managed Care Plan and ECM Enhanced Care Management. As I move into the next slide here, you'll see here what I just described is that on the top is the Mental Health Services Act. So these colorful green through blue through purple are those 5 existing funding components. As we move through into the next year, as Proposition 1 is going into effect and BHSA goes live July 1st of 2026, it moves into this category below the blue arrow, which is the Behavioral Health Services Act. What that means is all of the existing funding that we receive then gets transferred into really 3 new buckets of funding. This bucket here that's flagged by this red star means that 10% before it comes down to the county level gets taken off the top. It equates to 10%, and it gets divvied down to DHCS for state administrative costs, through HCI for workforce investment, and through CDPH public health at the state level for 4% of prevention. This is really important to remember because as we move forward into the Behavioral Health Services Act transformation, we lose all dollars that are allowable to prevention services, and that goes to the state level through CDPH. So taking this 10% off the top, the remaining dollars when it comes down to the local level gets transposed into these 3 buckets. The first bucket is very interesting, and this is the most controversial of the buckets because it does not currently exist within the current system, and that's the housing bucket. It is the area that we are most concerned about because the way to understand that is 30% of our funding gets taken off the top and transposed into what are now the requirements and the mandate of the housing bucket. And that is really to aid in supporting the homeless crisis and those that are experiencing being unhoused within our community. The next bucket, 35% of the dollars will go into full service partnership. Now, full service partnership currently does exist within our system of care. It exists under the community services and supports bucket as a component within that. But it will have a lot of new mandates that come online that are very expensive and that we will have to lift and have to transpose our current full service partnership programming into this new version of full service partnerships as mandated by the state. And then everything else in the MHSA that currently exists kind of dukes it out, as I've been saying, and fights for those additional remaining dollars that are available in this Behavioral Health Services and Supports bucket, also called BHSS. So it's a lot of converting over what will fit in our existing system into our new system, knowing that 30% will be taken off that top to kind of fulfill the new housing mandates that will come online. So the governor's overall vision was to transform behavioral health services. And this is really what went to ballot in March of 2024 and the voters voted on as Proposition 1. There were 3 pieces that were outlined in this platform for Proposition 1. The first was reforming the Mental Health Services Act to the Behavioral Health Services Act. The name change is really a shift in focus, if you will. Mental Health Services Act historically hasn't been inclusive of substance use disorder. And so moving it to this new phrase of Behavioral Health Services Act makes it inclusive of substance use disorder as standalone, allowable under the utilization of what was Mental Health Services Act dollars. And so that is why the name switched over. And that was representative in Senate Bill 326, if you were following along with the Senate bill language. The next item 2 here was really to enhance focus on outcomes, accountability, and equity, really focusing on a county integrated plan for behavioral health and an accountability across the state using a universal platform to report outcomes and accountability apples to apples throughout the state, county to county. And then the third piece here, if you were following the Senate bills and the Assembly bills, came in as AB 531, and this is the Housing and Behavioral Health Treatment and Unlock Community-Based Settings, 6.38 billion general obligation bond to build 10,000 new clinic beds and homes. And Morgan will be talking a little bit more about this later on in the presentation. So as I showed you a couple slides back in the colorful slides, this is another way to articulate the 3 new buckets coming online assigned to the Behavioral Health Services Act allocation. So we know that 30% will be taken off the top that will go towards the new housing bucket. 50% of that 30% must be spent on those that are experiencing chronic homelessness within our county of San Luis Obispo. And in a given year, no more than 25% of that 30% in the housing bucket can be spent on capital build outs, including behavioral health facilities to serve those that are unhoused. Moving on to number 2 here, full service partnerships. We talked about this. This gets a 35% of the Behavioral Health Services Act funding bucket. And then moving on to 3 here, the behavioral health community services and supports. That bucket will have 51% must be spent on early intervention and no longer allows prevention, and 51% on early intervention for youth. This slide here just shows you how to digest how this looks in San Luis Obispo County. So in San Luis Obispo County, we have 56 programs that exist under the Mental Health Services Act. These are kind of color coordinated based off of the buckets. So the ones that are in this red rust color are community services and supports, that CSS bucket. The ones in blue are prevention and early intervention. The ones in green are innovation, and the ones in purple are workforce education and training funded. So all of these 56 programs are at risk of either ending, off-ramping, or being changed significantly, or maybe being able to transpose into the new model. And this is how large this operates within San Luis Obispo County. Okay, so as we've been preparing in January, we made an announcement that we were going to start focusing on reductions and publicly announce those, and also vet those through our community planning process. And you can see here that we've experienced cost reductions for this upcoming year, fiscal year 25-26, and a reduction of 1.7 million. This is to our providers, SLO for 3 programs, TEMA of the multiple programs listed here in Community Counseling Center, and the SLO Behavioral Health Department also started to make reductions for our own workforce and some of our programmatic elements in preparation for the loss that we know we're going to have to mitigate and walk through to align into the Behavioral Health Services Act. Moving on, this gives you just a small infographic of BHSA impacts that we know that we are preparing for loss or change in. So the first one here is that prevention ends. Prevention is no longer an allowable area in which we can provide services. This would be inclusive of the work that we do in schools. This is inclusive of some of the outreach and education that we provide to the community. And there's a lot of different services that we provide that are no longer allowable because they align with prevention work. The next here is loss of school-based services. So we are trying to work very quickly with our Office of Education and all of our school districts within our county as we do a ton of work in our schools that is prevention focused. And so that will move away. Some of that will transpose into that new CYBHI fee schedule that I mentioned earlier. But we will have a reduction in some of the supports that we provide on campus in schools to some of our youth because of the change of Proposition 1. There's also a reduction in workforce education and training. This is not area that provides core services. And so it is an area when we are looking at that 30% being taken off the top, this is an area that we will lose in a reduction due to that movement of those funds. There's also a reduction in community outreach. Some of that is considered prevention, but we also know that we will no longer have the bandwidth to do this to the extent that we have years ago. Moving on to the next is suicide prevention is at risk. Suicide prevention is no longer protected the way that it was in the MHSA. And so it doesn't have a specific carve out. And so some of the work that we do in this lens will change significantly and is at risk. And we are waiting and watching how the rest of the guidance from the state will come out to show us how we can continue to provide suicide prevention to our county. We do know that, as I mentioned, MHSA moving to BHSA makes this expand to make substance use disorder programming more allowable under this Behavioral Health Services Act transposing of the system. And we will also know that we will have to invest as a behavioral health department to grow our ability to be experts in the field of housing. The behavioral health department historically hasn't been an expert in all things housing. And one of the requirements coming out from the state with the passing of Proposition 1 is that we have to know all of the inventory and everything that is available under the housing umbrella. And we have to vet and make sure that all of those resources are used before the first dollar can be used with the behavioral health department in that housing category. So we will have to gain very quickly a very large understanding of housing and how it works and all of the avenues and opportunities for housing within our county. And then, as I mentioned, there are a lot of evidence-based practices, standards, and programs that come alongside the full service partnership component. Those are new mandates. Those are very costly. And we will have to become experts in delivering those very quickly within the next 14 months to get our system aligned with the Behavioral Health Services Act mandates. And then we also know that, unfortunately, with some of our programs having to off-ramp or end or no longer being funded by MHSA, we will be experiencing loss in community-focused services. And so this is what we can see in San Luis Obispo County as some of the impacts that we are foreseeing and are preparing for as a county, working in collaboration with other agencies within San Luis Obispo County and our other departments within the county to prepare for the change of Proposition 1. And with that, I think I'll go ahead and pass it back over to Glenn. And there you go, Glenn.
Thank you. I appreciate that, Christina. Take your slides down, and I'd like to move on now to our next expert panelist. This is Morgan Terrell. Morgan is a business analyst in the County Behavioral Health Department. She works on new initiatives, programs, including the Behavioral Health Bridge Housing Program, a Proposition 1 bond grant application to add behavioral health treatment beds and mobile crisis expansion. So some more information about that housing topic. Morgan has 19 years experience working on issues of housing and homelessness, affordable housing, and behavioral health policy. She has a master's degree in public policy from Cal Poly. And so, Morgan, it's over to you. Thank you.
Thank you, Glenn. Let me get my slides up here. All right, just making sure you can see this okay. One moment here. Okay, Glenn, can you confirm that you can see this okay?
I can see it fine. You're showing the full range of slides. It's not the presentation format, but you can use this.
Okay, sorry, 1 second. Let me try this again. Keep showing that here. Thank you for your patience. I'm just gonna have to show this from here. I apologize.
Yeah, I wish I could help you. I'm just not a PowerPoint expert either.
All right, well, I'm gonna cover the bond portion of Proposition 1. Christina just covered number 1 here, the shift from the Mental Health Services Act to the Behavioral Health Services Act. So there was a bond portion of that as well that approved over $6 billion for both housing and behavioral health treatment beds. And you can see here, so about 4.4 billion of the funding is being managed by the Department of Healthcare Services for behavioral health treatment beds. And the first round was released last year in 2024, the big round of 3.3 billion. The state is planning to release or announce the awards this month. Round 2 will be released this month or next. So they're moving really quickly here. The second portion of the bond was almost 2 billion, and that's being administered through the Department of Housing and Community Development in coordination with CalVet for the supportive housing piece of it. And about half of that is set aside for veterans experiencing or at risk of homelessness with behavioral health conditions. And so the $4.4 billion portion of the bond is being allocated through a program called the Behavioral Health Continuum Infrastructure Program, or BSIP. And as I mentioned, that first portion was released last summer, and it's not for operations, it's for development of the beds. And the state has a number of priorities here. This is just some of them here. They're focused on addressing urgent gaps in the behavioral health continuum of care and increasing options that serve as alternatives to incarceration, homelessness, and institutionalization. They also want to meet the need of the most vulnerable populations that have had barriers to access and leverage our ongoing Medi-Cal investments for sustainability. And there's a number of studies and reports that informed both Proposition 1 as well as our local application. The statewide assessment on behavioral health continuum was completed by the state in 2022. That report states that nearly 4.5% of California adults have a serious mental illness and about 9% have a substance use disorder. Many of those adults are enrolled in Medi-Cal receiving services through counties. Additionally, it notes that treatment options are vital for children and youth, and it shows that SLO County is one of the few coastal counties without crisis residential services and treatment. Crisis residential is a step down from inpatient services. Additionally, the report shows that there are not enough inpatient beds in the county. Some of the statewide goals identified in Proposition 1 are increasing care and access for patients and prevention and treatment of co-occurring physical health conditions. You heard Christina mention that prevention is not part of our bucket planning, but they shifted over, notice the physical health piece, they shifted over some of the MHSA fundings to public health to release funds for the physical health piece of it for prevention. And also some of the goals are to increase quality of life and social connections as well as engagement in school and work. And some of the state's goals for reductions are to reduce suicides and overdoses, to reduce untreated behavioral health conditions, institutionalization, homelessness, justice involvement, and also reduce the removal of children or removal of children from home. Also here, so at the local level, behavioral health completed a strategic plan last year. Prior to that, not long before that, there were gaps analyses completed for both youth and adult. So some of the strategies included in the strategic plan are listed up here. They include building community understanding of crisis management, expanding sobering center and/or inpatient beds for individuals in need of substance use related services. One thing to note is a sobering center did open last year on our health agency campus. It's 12 beds. So that is now in place, and also extending the engagement and length of crisis services to provide a bridge for longer term services. And on the intensive residential piece of it, there's also a number of strategies identified, including expanding access to residential facilities for inpatient treatment, exploring regional approaches, and ensuring access for both youth and women, partnering to increase step-down opportunities, so filling in more options that are not inpatient between inpatient and outpatient services, and exploring multi-county regional approaches. And then this gaps analyses that I just mentioned, there were a number of items identified, but on the youth piece of it, high level, it recommends creating treatment beds. There are none in San Luis Obispo and Santa Barbara counties. So other than someone going to the emergency room, so it recommends crisis stabilization alternatives. And in the adult services piece, some of the items are listed here too. So that we are in need of more inpatient services, it recommends investing in crisis residential and another psychiatric health facility. So all of that, I mentioned all of that just to inform, our proposal that was submitted in December for the first round of behavioral health treatment beds. And it includes an almost $22 million application to the state that would add a 16-bed inpatient psychiatric health facility. 4 of those beds would be set aside for youth. It also includes 8 beds of adult crisis residential and up to 4 beds for youth crisis, youth that could stay in crisis residential. So kind of to recap that crisis residential, it's a voluntary therapeutic environment and people typically stay less than 30 days. So someone exiting an inpatient facility could exit to a crisis residential. So it's addressing a number of urgent gaps. A couple of these are listed here too. So it would add the first youth beds, and it would provide a step down from inpatient services, and it would provide more local collaboration between systems and more integrated services and diversion from other facilities. I mentioned that we will hear this month if we're awarded funds, and if we are successful, we would go to the board this summer to request that we accept the grant. And the round 2, as I mentioned, will be released this month or next statewide, and it's a competition between our region and counties statewide. And then finally, I just have this one slide on the permanent supportive housing piece of it. So there was a round that closes this month. Applications are due in May to the Housing and Community Development Department. And there's one application that I'm aware of. It's between the County Department of Social Services and Restorative Partners. That would be up to $7 million to acquire and renovate a property that would result in 34 permanent supportive housing units. Now I will hand it back to you, Glenn.
Oh. Thank you, Morgan. That was a daunting process to go through all that money in all those places it can go. I think there's going to be a lot of questions, I hope. I'd like to make a change now. We're going to move on to our final panelists. This is Barry Johnson. Barry is the Deputy Director of Transitions Mental Health Association. He has worked in a variety of mental health settings since 1990 and has been a TMHA Director for the past 25 years. He's provided administrative oversight on MHSA programs, including vocational suicide prevention, outreach and family services, and many others. Barry is passionate about trauma-informed care, LGBTQ and BIPOC equity and inclusion, and the value of employing people with lived experience. And with that, Barry, you're on. Thanks.
Thank you, Glenn. Sharing screen, you can see that okay, I assume. Good afternoon, everyone. Barry Johnson, Deputy Director with Transitions Mental Health Association, and really appreciate the invitation today to speak about this very timely and important topic. So Christina and Morgan have done all the heavy lifting here as far as laying the groundwork and the scope of what the behavioral health transformation is bringing to us. I think my task today is just to give you a quick snapshot of the challenges that CBOs are facing, primarily what our organization's Transitions Mental Health Association is facing, and then also talk about some of the opportunities that are arising. Transitions Mental Health Association is a nonprofit that's been in our community for over 40 years. We serve San Luis Obispo County and northern Santa Barbara County, a variety of services, including housing, wellness centers, family services, peer services, and youth programs. There we go. So as Christina mentioned, 2004, Prop 63 passed. Next year, Mental Health Services Act came into play, and it truly was a transformation of our system. Up until that point, for county services and CBOs that were providing county services, most of our like our wellness center, our education, the work that we were doing in the community was only available to folks who had an open case with behavioral health, at that time mental health. Mental Health Services Act changed all that. It opened up the doors really to all Californians using a prevention lens to help circumvent any issues that might require a more intensive level of services. There was a focus on underserved populations, including LGBTQ, veterans, and youth, teens. And there was a focus on peer and family-run services. Through Prop 63 and the Mental Health Services Act, many innovative programs were able to come to fruition. And there's a list right there as far as peer health navigation, family services, high school program, which is teaching Mental Health 101 and suicide prevention and health education classes, full service partnerships that Christina talked about, supported employment, helping folks find and get and keep employment. And then our wellness centers that do a variety of psychoeducation and support groups. All of those programs, except for the full service partnerships, are on the cut list either for this coming fiscal year or July 1, 2026, when the Behavioral Health Services Act is enacted. So we all know prevention works. An ounce of prevention is worth a pound of cure. And it's no different in behavioral health. We have research and, of course, our own outcomes that show improved mental health outcomes, increased resilience, improved emotional regulation, improved relationships and connections and quality of life. We see all of that through our employment programs, our wellness centers, the work that we do with our peers, people who have lived experience walking side by side with others to support them. We see reduced hospitalization rates in all of our programs. The 89% here is just one vocational program. And then as far as the cost of crisis services, we see one day at a wellness center, $93, one day in slow inpatient, $2,271. It's not to say that we don't need the inpatient and it's not a critical service to provide, but the service is impacted as well as ER and hospitals. These programs, our prevention programs, help to alleviate that, and it's in the word, prevent it. These are the current program cuts, as Christina alluded to, for our organization, Transitions Mental Health Association. They include family education, peer education, the high school program that I mentioned, the community outreach and education that we provide, whether it's at health fairs or going to different organizations to give them information about mental health services in our community, helping to increase access. Forensic reentry services. These are navigation services coming out of the jail. Our behavioral health navigators, again, folks with lived experience who are walking side by side with others to help them find housing, get their income in check, make connections, and also to provide support when needed. And also our Growing Grounds Nursery is on the cut list. This is a total of about $700,000 in cuts. The nursery is not a Mental Health Services Act funded program, but with all of the cuts that our county partners are facing from federal, state, and county level, it is an impact throughout our funding for services. And then programs at risk, going into July 1, 2026, when Prop 1 comes into play, in addition to the programs that are being cut this year, our wellness centers, our growing grounds downtown, our family services, and our supported employment programs are all on the list that Christina put out earlier, that shows just the high level of impact that Prop 1 might have and is most likely going to have. So our organization, along with County Behavioral Health, we're very much committed to the idea of prevention. We're very much committed to being as upstream as possible. And so even though this is really the heaviest shift any of us have seen in behavioral health, certainly I've never seen this level of change in the 30 whatever years that I've been doing it. And we see change all the time. We just don't see it coming all at once. And there's no specific roadmap. And so the key to moving through that is collaboration. And fortunately, we do have a very strong history of collaboration with our partners at SLO Behavioral Health, as well as public health, and throughout the county. Other opportunities that will come from Prop 1, both Christina and especially Morgan outlined as far as increased housing opportunities. And we embrace the opportunity to bring more substance use disorder treatment and training and conversations into the work that we do with our mental health folks. Also, another opportunity is more enhanced services, increased services, even as we maximize Medi-Cal billing. That leads to some of the changes that, or some of the that list that Christina provided as far as different opportunities and funding streams that are part of the behavioral health transformation. We are very much looking at CalAIM. Some of the programs that I mentioned that are being cut this coming fiscal year, we'll actually be able to salvage our peer navigation programs. We're working in collaboration with San Luis Obispo County Behavioral Health to bill Medi-Cal for the complete service. And so we're looking at more and more ways to maximize Medi-Cal billing so that it does cover these much needed prevention services. CalAIM also has helped to streamline and reform how documentation takes place and the billing mechanism. So that's a positive. It's much easier for our line staff to document the services that they're providing and for that to turn into a Medi-Cal billable service. The other thing that we're looking at is enhanced care management and community supports to provide some of those prevention pieces, especially within our family services. This is serving mild to moderate, which is a typical prevention realm for us. And through our family services, especially helping families navigate the trials that can come up when a loved one has a mental illness. And then some of these have already been mentioned, but there are evidence-based practices coming through BH Connect that'll increase our fidelity with our FSP teams, which is also exciting. It just increases the level of treatment and the outcomes that we'll see with our FSPs. There's an opportunity to look at a clubhouse model, which is more of an employment type of service for folks who maybe want the socialization piece with their peers, but also want to get back into the workforce. And related to that, there's individual placement and support, which we are looking into, which matches very well with our supported employment program. And as Christina mentioned, there's the Children and Youth Behavioral Health Initiative. We're currently funded through that for our positive parenting program, providing education and guidance for parents of youth. We're also in conversation with offices Ed, how we can continue our health education classes. And I know that the schools are looking at school-based wellness centers and wellness coaches, and this is something that we applaud and support and look forward to coming into our system. So that was a quick run through for me. I think in short, there's a lot of cuts on the table. There's a lot of transformation and shifting happening, but there's also a lot of different opportunities that we can look to really recreate our local system. 20 years ago, we brought the Mental Health Services Act in play. I believe it's been a great thing for our community. And so now it's our job to rebuild and make sure that the folks in our community are taken care of. And with that, I think I'm going to pass it over to Leslie.
Okay. That was a lot of information, I know. We have actually 3 questions. So I think we'll be able to answer them all unless the information provided prompts more. This would be, I think I'll direct this to Christina. What is the difference, practically speaking, between early intervention and prevention? And why the shift in focus to and the restriction on prevention services?
Yeah, that's a big question. So under the Mental Health Services Act, historically, we've categorized programs as prevention programs or early intervention programming. And so we already have them kind of grouped into those buckets. We have to report those to the state every year. So we understand prevention versus early intervention a certain way. Prevention's usually upstream approaches that are used to reach individuals before they've entered into our service of care, or maybe our true preventative measures of care for mental health or co-occurring challenges. Barry mentioned mild to moderate needs. So an individual that may be experiencing mild to moderate needs may not need especially mental health care quite yet. And so that may be deemed as a prevention category or prevention programs that a person would exist in the service delivery model. Early intervention services can look similar to prevention services at times, but are typically used for individuals that are exhibiting risk or higher risk and need, but may not have entered quite yet into specialty care models. So it is the mandate of the county to serve Medi-Cal recipients that have specialty mental health needs or substance use disorders. And so if they're meeting criteria for mild to moderate, they may end up more in that prevention bucket. So hopefully that makes sense of what the difference between the two are. Also understanding the big question, which is the why is prevention no longer allowable? Some of the information that's been shared with us from the state is that, prevention, because it doesn't align necessarily with the specialty mental health population, the highest level of need, prevention can be picked up in other areas. So if it's outreach prevention, that might be done through the larger campaigns that'll come out through public health at the state level. And we know that with 30% taken off the top with housing, that room has to be made in that funding. So I believe that prevention and what's been articulated to us is it's prevention's kind of excused from the equation to make room for the new housing mandates that are coming online.
Okay, thank you. I think this question goes to Morgan. How will behavioral health grow their expertise in housing? What is the plan for that?
Yeah, I'll start, but I think Dr. Rajal will probably want to add to it as well. And it is physically going to be in her shop as part of the MHSA to BHSA transition, but there are a number of things that, across the state, all behavioral health agencies will be working on together, because this doesn't just affect us. Some of it will be, we anticipate to have some training from the state or our partner entities. We also work closely with social services, who has contracts with our housing providers. We have contracts with Transitions Mental Health and some others that have that expertise. So some of it's a shift in what's happening now, and some of that local knowledge will be, worked on together in teams. But I think Christina might want to add more to that.
Yeah, so Morgan and I are working side by side on this one quite a bit. So as mentioned, what we're going to do for the behavioral health department is we're looking at actually creating a housing team that will help to grow our level of expertise in the county. So I mentioned that one of the things that we have to be able to do, I have to wear what I kind of make light or joke of this is I now have to kind of have my construction worker's hat on. I have to be a builder. I also have to be a landlord. And these are skill sets that the behavioral health department usually has not historically ever had. And we have to have this level of expertise so that we can vet and ensure that every dollar available through other source funding has been leveraged first before we can even spend that first dollar in housing. So I really, really need to be an expert here in housing to understand how we do that before we spend the first dollar. It's reportable in our annual report that we have to send to the state now that is mandated. And so we're being very careful that we start to build the level of expertise that we know we're going to need to be able to implement this well and thoughtfully to a very vulnerable population within our county. And so we are looking at building our infrastructure internally to bring on a housing team that will be housed within my division in the Mental Health Services Act team to help support this vision of how we grow this. We'll also be partnering, as Morgan mentioned, with Department of Social Services, with a possible liaison that can work between homeless services, which is housed in their department, and our MHSA, BHSA team to work smarter about how we support individuals in our community that are unhoused or at risk of homelessness. So we have a lot of work to be done in 14 months to get there. Morgan's shop and the things that live within her shop also have a place within this equation. So we are working diligently on the state level, really understanding the requirements and what is allowable so that we can bring this on quickly, but also very thoughtfully.
Thank you. You will be busy.
Definitely.
This is a quick question, actually, to Morgan. Will the slides that you have on the bond administration be available? I do have your contact information on the final slide, so maybe people who want to reach out could get those.
Absolutely happy to share them.
Okay, great. And then not so much a question, but a comment. There's been little mentioned about what is laid out for mental health concerns of seniors and who might actually be in higher risk. So I'll open that up to anybody who wants to speak to that.
I can jump on that one too. Yeah, so Mental Health Services Act historically has age grouping categories. So there's our young ones, then there's our like transition age youth. So our children are transition age youth, which is teen up until 25. Then our adults, and then our older adults. And we have to report all of our programs in those population by age groups. And that's a requirement. That goes away with the change into BHSA, meaning that the older adult category is no longer a category. It kind of rolls into just the general adult category. So we're waiting on more guidance from the state because although Proposition 1 is passed and all the legislative language has passed, not all of the interpretation as to how we interpret that not all that guidance has dropped or landed. We've been waiting and walking alongside the state as they drop each of those. They're calling those modules, draft modules of how we are to understand the ruling and how we move forward. So we're waiting on more guidance, but we do recognize and understand that there's no longer a set alone older adult category, that it is allowable to just be wrapped into adults. So as we move forward, and we look at how the rest of our cuts land, we're going to see where that fits within the equation of services moving forward. There will be, we won't be dropping our services to the older adult community, but it will look different than it does today.
Okay, thank you. And we've got a couple more minutes. We have one more question. how will the substance use disorder component of behavioral health or BHSA be different than the work that is already being done by Drug and Alcohol Division of Behavioral Health?
Yeah, that's a great question. So we don't actually think that it's going to look different than it currently operates. We are pretty integrated with our care. We do a ton of work with substance use disorder and how we wrap around individuals in our community that need services and support. However, Proposition 1 affects all of the state. And so this doesn't look the same county to county in other areas, where other areas really may need the benefit of this being broadened into the Behavioral Health Services Act. Meaning, historically, with MHSA in 2004 and 2005, it was not allowable to spend any dollars on substance use. A couple years ago, maybe about 3 or 4 years ago, that changed and it made it allowable for co-occurring, meaning that individuals that had behavioral health and substance use could then be receive care through Mental Health Services Act funding. Now what this does is standalone substance use can be funded if a county deems that that is funding stream that they would like to use. We are very robust in our services already for drug and alcohol services for adults, which lives in Christina Paramore's shop, and youth treatment lives in my shop in prevention and outreach. We already do a ton of services and reimbursable services as well. So this is not something that we're looking at a huge build out. We already do it pretty well here in our county, but it may look different or the impact may be different throughout the state and other areas.
Okay, thank you. One more question has just come in for Barry. Are you aware of conversations ongoing about what it means to push further upstream with our trauma-informed social analysis? Macroeconomic tie-ins, cultural tie-ins that isolate people and create trauma-conducive social context. Hopefully I read that correctly.
Yeah, I'm going to read it as well. The conversation's ongoing about what it means to push further upstream with our trauma-informed social analysis. Macroeconomic tie-ins, cultural tie-ins that isolate people and create trauma-conducive social context. I am not aware of that specifically, but what I and my team and the work that we do with public health and DSS and behavioral health is really utilizing the trauma-informed lens as we move into this new era where prevention is not in play. And so as we're going out into the community, it's more important than ever for us to have that trauma-informed lens. I would be very interested in talking to you more, though, about those concepts.
Well, that's a good way to wrap it up. I really, really appreciate your participation, panelists. Given what we've heard, we know that you are extremely busy, so we really value your time. We're going to wrap up the webinar now and say goodbye. And we will show that final slide so that people can reach out to the panelists if they'd like to get some more information. So thank you very much. Have a good rest of your day.